between you and your lunch. But believe me, I'm going to keep it simple, something that you do every day as intensivists. So it is just a revision, a quick recap, all right? First of all, thank you, Chirag, for having me here, talk in front of such an erudite audience. I bring in greetings from Medanta, and I'm talking about meningitis and encephalitis, the infectious neurological emergencies. We've been dealing with emergencies throughout the day, and now we come on to the infectious part. These are the two emergencies that require prompt recognition and treatment to prevent significant morbidity and mortality in the affected population. The reason is, if you don't treat it promptly, you will be left with neurological sequelae. All right, so what is your management approach like? You have to recognize the meningitis syndrome early in its phase. You have to evaluate this syndrome rapidly, and you have to start your therapy emergently. And this means you're not waiting for any of your tests. You are beginning your antimicrobial therapy as soon as you have a clinical suspicion of meningitis or encephalitis. So what is meningitis? What is encephalitis? You all know inflammation of meninges is meningitis. Inflammation of brain parenchyma is encephalitis. When you just have meningitis, you'll have symptoms of meningeal irritation, that is headache, fever, stiff neck, etc., etc. But if you have parenchymal involvement, the patient would present to you with seizures, with focal neurological deficits, because the parenchyma of the brain is involved. Now, the diagnosis of acute infective meningoencephalitis is suspected in a febrile patient who presents with altered consciousness and signs of diffuse cerebral dysfunction. So always suspect meningitis or encephalitis in a patient who presents to you with fever and altered sensorium. And if he has seizures, your diagnosis is facilitated. So in a study from India in pediatric patients, the commonest cause of acute febrile encephalopathy was viral encephalitis, accounting for around 40% of cases. And among the non-viral causes, bacterial meningitis was the commonest, accounting for 33.8%. Tubercular meningitis was in 7.9%, although the incidence might be higher. The diagnosis for TBM is really challenging. And cerebral malaria, which is 5.2%. So what are the causes? Viral, the commonest. And in viral, what needs prompt recognition is herpes simplex, as you all know, HSV encephalitis. The most deadly form of viral encephalitis, if not treated promptly, would lead to severe neurological deficits in your patient. So you have to hit it early. All right. So apart from herpes simplex, you have other DNA viruses and RNA viruses, but all these viral encephalitis syndromes are milder and usually self-limiting. What you need to do is simple symptomatic therapy for them. Amongst the bacterial, we have acute pyogenic meningitis. We'll discuss the etiology in greater detail. We also have rickettsial infections leading to meningitis, fungal meningitis, and parasitic in endemic areas like Plasmodium, the cerebral malaria part. All right, so we talk in detail about the bacterial meningitis etiology. A patient comes to you with fever and altered sensorium. He would be a case of a community-acquired meningitis, might be a case of community-acquired meningitis. So the commonest organisms that you think in this case is strep pneumonia, of course, and Neisseria and Haemophilus influenza. I can see everybody is asleep in a state of stupor. All right. So, but if the patient is elderly and immunocompromised, Listeria and Strep tegelectii, along with gram-negative organisms, is what you should suspect. Am I clear? Yes. If the patient is suspected to have a hospital-acquired infection, patients who had a CSF leak post-surgery or who had a CSF leak after a road traffic accident, you should aim for therapy against staph, most of which is resistant, and resistant gram-negative organisms. I'm not talking anything very complicated. I mean, you would be doing it every day. All right, so a detailed workup is necessary. The classic triad in the history is fever, stiff neck, and altered sensorium, but only 46% have this classic triad. 99% will have at least one feature, and this puts you in a difficulty to diagnose. Look out for the risk factors: asplenia, prosthetic devices like VP shunts, HIV, diabetes, Patients on immunosuppressive therapies, steroids, CT, RT, all of these put a patient into an immunocompromised state. So you should also talk about the geographic and seasonal factors, any animal or dog bite, foreign travel, to talk of endemic causes for meningitis. Mode of onset and progression of symptoms is very important. Anything that is rapidly worsening clearly indicates that the patient has something like acute meningitis. So have a high degree of suspicion. In the physical examination, Koenig's, Brodzinski's, you would have all read them in your MBBS days. They might not be very sensitive or specific. Okay, so Koenig's would be pain in the back and legs after flexing the hip and extending the knee. Brodzinski's may be passive flexion of neck leading to flexion of the hip, and there is something called jolt accentuation also, where the existing headache gets exacerbated with rapid head rotation. I mentioned these only to complete. All right, you have to look into the skin and mucous membrane. There may be skin rashes in meningococcal patients. The skin labs, CBC, coagulation, liver functions, renal functions, ABG. So you may have relative lymphocytosis in viral encephalitis, leukopenia, and thrombocytopenia in rickettsial infections, and peripheral blood film, obviously, you know, for malaria. You have always to send blood cultures in patients who are suspected to have pyogenic meningitis, but these may be positive in only 30 to 80% of patients. Chest radiography may point towards the possibility of mycoplasma or tuberculosis, a miliary TB, a mycoplasma infection. Now comes the diagnostic test of choice, your lumbar puncture. So how many of you agree that we should delay lumbar puncture, we should delay antimicrobial therapy for lumbar puncture? How many of you don't start antibiotics until your lumbar puncture has been done? One. Otherwise, everybody starts antibiotics? Yes. Okay. Now, for lumbar puncture as well, you have to look for a potential risk of brain herniation if the ICP is too high. So what are the IDSA guidelines where they say that you should have a CT prior to initiating a lumbar puncture? All elderly patients, patients who are immunocompromised, who have a history of CNS disease, a mass lesion, stroke, or focal lesion, new onset seizure in the past one week, or an abnormal neurological finding such as papilledema, depressed level of consciousness, focal neurological deficit. So you need to rule out a mass lesion prior to doing a lumbar puncture so that your brain doesn't herniate after your lumbar puncture. All right, so when you perform an LP, what do you look for? The opening pressure, of course. The first thing that you look for is your opening pressure. Normally it is 10 to 20 centimeters in the lateral decubitus position. You look for turbidity. A patient with pyogenic meningitis will have a turbid CSF. You look for cytology, the number and type of cells. The normal number, okay, it is 0 to 5, and the type is lymphocytes. Biochemistry, glucose. Glucose is okay, at the time of CSF analysis, you need to do a random blood glucose as well in order to compare. So if it is less than two-thirds of the plasma glucose, you may have a CSF suggestive of meningitis. You assess the proteins, you assess CSF lactates. How many of you do CSF lactates routinely in your patients? No one. No one. No one. Okay. CSF lactates may be really helpful in patients who have hospital-acquired infections. In post-neurosurgical patients, CSF lactates may be really helpful. Gram stain culture, I think all of you send. Zeal-Nelson staining, AFB smear for TBM, India ink staining for fungal meningitis. So this is how a normal CSF picture is like. You have a pH of 7.4 with a specific gravity of 1.006 to 1.007. Normally, there are 1 to 5 cells, all of them lymphocytes. Proteins are 15 to 45. Glucose is usually 50 to 80. And there are no pathogenic microorganisms on microbiological examination. And this is the CSF picture in meningitis, something which was really important for you to see. So we'll talk about each of them in detail. If the patient has bacterial meningitis, your opening pressure will be elevated. So an elevated opening pressure points towards a pyogenic cause of meningitis. For the leukocytes, number of cells, there would be a pleocytosis in meningitis. The cells are going to be more than 1,000. The cell differential, there would be a neutrophilic pleocytosis in bacterial meningitis. Neutrophils will be predominant. For proteins, proteins will be high. Glucose, low. So a low glucose level, which is less than 2/3 of your plasma glucose, would point towards a bacterial meningitis or a tubercular meningitis. Even in tubercular meningitis, you may have low glucose levels in the CSF. All right, talking about viral encephalitis, the opening pressure is usually normal. There is leukocytosis, but the differential is, in the early phase, you may have neutrophils, but usually it is lymphocytic predominance. Proteins are high, and glucose is usually normal. The cultures are, of course, negative. For tubercular meningitis, tuberculosis, this is a very challenging diagnosis. I mean, you may not be 100% sure if your patient has a TBM or not. So the opening pressure is variable. Leukocytes, okay, leukocytosis is present. It is usually lymphocytes. Proteins usually are very high. The point is that these patients have a low glucose in the CSF along with very high protein levels. All right, and the cultures may be positive for AFB. We nowadays have the Mycobacterium PCR. All right, so we have PCR to know the causative organism these days. We can detect all the bacteria, Neisseria, Haemophilus, Strep pneumonia, Streptococcus lactii, and Listeria. For viral meningitis panel, most of the viruses are covered. We have cryptococcal antigen. In tuberculous meningitis, we usually go for a gene expert, Mycobacterium tuberculosis PCR, nucleic acid amplification tests. Some centers would also do ADA. We are not too much in favor. The lab tests that help to distinguish between bacterial from viral meningitis are CSF lactate levels. Now, CSF lactates are particularly helpful in postoperative neurosurgical patients. The lactates, if they are more than 4.2, CSF has a normal lactate of around 4. So if it is more than 4.2, it is 100% specific for bacterial meningitis. So a good one. CRP concentration, a normal CRP has a high negative predictive value. If your CRP is normal, think that there is no meningitis. Procal again, serum procal has 100% sensitivity and specificity if it is high. But talking about CSF procal, there are not too many studies, and whatever studies are available, they say it might not be 100% specific or sensitive. PCR, yes, of course, PCR is the gold standard. Talking about a bacterial meningitis score, you have a positive gram stain, which is given a score of 2, a CSF pleocytosis, protein levels more than 80, peripheral blood ANC more than 10,000, and a history of seizure before presentation. All of these are given 1 point each, and if the score is between 2 to 6, bacterial meningitis is more likely. So this has a 99.9% negative predictive value. If the score is less, you may not think of bacterial meningitis. What about neuroimaging? How many of you do an MRI as soon as you suspect a case of meningitis or encephalitis? How about an MRI? 1, 2. All right. How about a CT? Okay. CT scan is simpler. It helps us to rule out a mass lesion or an abscess before doing a lumbar puncture. And if the patient has viral encephalitis, it may even show changes, frontotemporal changes. So MRI, we prefer because you can look for leptomeningeal enhancement. Complicated tests are indicated only when your diagnosis becomes challenging, when you face a difficulty. If you perform a simple CT, go in for a lumbar puncture, and you have reading suggestive of frank bacterial meningitis, why would you need to do MRI brain for diagnosis? All right, so the characteristic neuroimaging changes may be frontotemporal changes in herpes simplex encephalitis. In TBM, we may have basal exudates or multiple ring enhancing lesions, and thalamic midbrain changes in Japanese encephalitis, lesions in brainstem basal ganglia in Eastern equine encephalitis, and so on and so forth. So this is a typical MRI of a patient with a herpetic encephalitis. You have frontotemporal changes. In TBM, you have a typical tuberculoma, a ring-enhancing lesion. You may have gross basal exudates on your imaging. How about an EEG? EEG, if a patient has presented to you with seizures, it may help you in differentiating a patient with viral encephalitis from a patient with a generalized febrile encephalopathy. All right, so in encephalopathy, there would be a diffuse slowing, but in herpetic encephalitis, there would be plaids coming on from the frontotemporal lobes, which may be affected. All right? So EEG may help you. Coming on to the management, how do you manage these patients? I mean, all of you would be managing them, and I don't really need to discuss these. You would all know them. I have a high alert. It is an emergency. The golden hour management, very important. Assess the ABCs, airway, breathing, circulation. If your patient needs airway support, give him circulation, appropriate fluid resuscitation, go for a blood glucose, measure the vitals, assess the GCS, and start on parenteral antibiotics. While there would be ample literature to say in sepsis, the golden hour rule is start antibiotics as soon as you see a septic patient. Similar is the case with meningitis encephalitis. Now, as soon as you suspect a case to be a case of pyogenic meningitis, start antibiotics, because even the most sensitive of organisms would take at least 6 hours to CSF sterilization. So make it a point, perform your LP within 6 hours, but then start your antibiotics. And what kind of antibiotics? They have to be broad spectrum. They have to cover both gram-positive and gram-negative. A patient comes from a community, you have to cover both strep as well as Neisseria, Haemophilus E. coli. It should have a reasonable CSF penetration. That is the golden rule. Antibiotics with reasonable CSF penetration are the ceftriaxones, meropenems, etc., etc. I don't need to reiterate. And most importantly, they should be bactericidal. And here comes the question, why vancomycin and not linid? I have been talking about this every day, everywhere. Linid has an excellent CSF penetration, and still we prefer vancomycin over linid. The reason is, vancomycin is bactericidal, while linezolid is bacteriostatic. You have to hit fast, hit hard. So you adopt an antibiotic which has a broad spectrum, which has a reasonable CSF penetration, and which is bactericidal. So I talked about this. CSF sterilization would take 4 to 6 hours after the initiation of antibiotics. So which antibiotics to start? I think all of you do this. You start monoceph vancomycin, isn't it? Ceftriaxone, a third generation, and vancomycin in a dose of 1 gram BD. If you have suspected VP shunt infections, or for that matter, community hospital-acquired or nosocomial infections, you should be treating with an anti-pseudomonal cephalosporin. So start cefepime or ceftazidime, or you can go for meropenem to cover the resistant gram-negative organisms like Pseudomonas and Acinetobacter along with vancomycin. And if your patient is elderly, immunocompromised, do not forget to start ampicillin empirically in order to cover listeria. So ampicillin, a dose of 2 gram IV 4th hourly in elderly and immunosuppressed patients to cover listeria and strep A. galactiae. And this is the same thing that I have been discussing. Strep pneumonia needs vancomycin plus a third generation. Neisseria needs a third generation. So does Haemophilus influenzae and E. coli. And for listeria and strep A. galactiae, you need ampicillin. All right, and this is the age-wise. Age-wise, for infants, less than, for neonates, I wouldn't say infants. For neonates and elderly, you have to cover for the listeria and strep A. galactiae. All right, so in patients who have a suspected herpetic encephalitis, you should immediately start antiviral drugs, acyclovir, dose of 10 milligrams per kg 8th hourly. Empirically, you have to start, and you can switch it off once your tests come negative. So that is not a problem. Relatively safe drug in case you take care of your renal functions. Hydrate the patient properly. All right. It may be withdrawn after exclusion of herpetic encephalitis, as it is not effective against other viral encephalitic syndromes. In immunocompromised patients with suspected fungal meningitis, of course, you have to start ampho B, liposomal amphotericin B, 3 to 5 milligrams per kg IV daily. And this is the specific antimicrobial therapy based on isolated pathogen and susceptibility testing. I think we've covered, depending upon the organism. All right, vancomycin plus a third generation cephalosporin. In all of these, if you have Pseudomonas, you need to start an anti-Pseudomonal cephalosporin, cefepime or ceftazidime, or you may go on to meropenem. In case of staph epidermidis, I need to mention this because you have patients of VP shunt infections in your ICUs. Now, for VP shunt infections, the commonest organism is coagulase negative staph. So you need to cover for coagulase, for cons as well. So you may go in for vancomycin And if it is not helping, you may go for linezolid. A very common practice, you may encounter a lot of case reports if you go through the literature. If you have an infected BP shunt, the usual practice is exteriorize that shunt. Don't let it stay in your brain. So what do is they administer IV linezolid and they give intraventricular vancomycin for it to be effective. I don't know how many of you have done that, but that works really effectively. Okay, and for Enterococcus species, it is a tough organism, so you may have VREs. In VREs, you have to give linezolid. All right, new kids on the block, the MDRs, gram-negative bacilli. Acinetobacter species have become more common in patients with nosocomial meningitis. I think all the patients who come for tertiary care to your hospitals usually have these resistant, multi-drug resistant gram-negative bacilli, isn't it? So what do? They are resistant to everything, for cephalosporins to carbapenems and everything. So empirical treatment is what we do usually is we start with meropenem with or without an aminoglycoside. And if the organism is subsequently found to be resistant to carbapenems, we start with colistin. But colistin has a very poor CSF penetration. So what needs to be done? An intraventricular antibiotic. All right, I'll discuss about the intraventricular once again. Before that, what is the duration of antimicrobial therapy based on the isolated pathogen? Now, it is not proven. Please do not consider it as standardized. They say for Neisseria, Haemophilus influenza, you may treat only 7 days. I don't know. Strep pneumonia, strep tegelectii for 2 to 3 weeks, and for all resistant gram-negatives and listeria for 4 weeks. Our usual practice, the most common organism that we encounter is gram-negative. We usually treat for 4 weeks at least. Role of intraventricular. So why do we administer intraventricular? It should be considered in patients in the presence of highly resistant organisms, sensitive to antibiotics with poor CSF penetration, in which the infection responds poorly to systemic therapy alone. And which are the common antibiotics that we give intraventricularly? They are, any experience? Colistin, vancomycin, amikacin, or you may also give teicoplanin, tobramycin, poly-B, but these 3 are the commonest. We usually give colistin and vancomycin if need arises. So to provide bacterial eradication, it is necessary to have drug concentrations in CSF 10-folds of the MIC. 10 folds more than the MIC value of the pathogen, and after administering, you have to clamp your EVD for 15 to 60 minutes to allow the agent to equilibrate throughout the CSF. And which are the common drugs and their dosing? Let me just reiterate colistin. Colistin, the dosage is usually 50,000 units that we give. And for vancomycin, we usually administer 10 milligrams intrathecal. Anybody else may have different experiences. After administration of the first intraventricular dose, additional doses can be determined by the calculation of an inhibitory quotient. So subsequent doses, after the calculation of an inhibitory quotient, you get a CSF, you measure the trough CSF concentration for that antibiotic, and you calculate the inhibitory quotient as trough CSF divided by the MIC of the agent. So inhibitory quotient more than 10 to 20 is required for consistent CSF sterilization. Coming on to viral encephalitis, quickly, we've discussed this. Herpes simplex needs empirically starting acyclovir in a dose of 10 milligram per kg thoroughly, and you have to ascertain a normal renal function. And for all others, it is usually self-limiting. What are the predictors of an adverse outcome in such patients? Age of the patient more than 30 years. If your patient presents to you with a poor GCS, if the symptoms before starting antiviral therapy is more than 4 days, so there has been a delay in therapy, it may prove to be an adverse outcome. The treatment for non-herpetic, largely supportive. A negative CSF PCR at the end of therapy is associated with a better outcome. No points in guessing that. All right, the last thing that I have in my presentation is steroids. How many of you go for steroids in meningitis? Quite a few. All right, yes, no, maybe. Even the senior-most intensivists have a doubt whether we should start or not start. Some say yes, some say no. So I have some evidence for you. Cochrane Database Review 2005 for acute bacterial meningitis. Corticosteroids significantly reduced hearing loss and neurological sequelae, but did not reduce overall mortality. So in bacterial meningitis, what do? We usually start steroids, IV dexamethasone, prior to initiating antimicrobial therapy. If your CSF turns out to be strep pneumonia positive, we continue it for 3 to 4 days. All right. If it is some other organism, we might as well stop it. So empiric use of steroids concurrently with antibiotics in all adults suspected with bacterial meningitis may be reasonable to prevent the release of inflammatory cytokines. The dose is 10 milligrams, 6 hourly for 2 to 4 days. It should, however, be continued only in patients with culture positive for pneumococci and should not be given to patients who have previously received antibiotics. If your patient comes to you who has received antibiotics outside, there is no point in giving steroids after that. All right, for TBM, another Cochrane review, 2016, for managing tuberculous meningitis, corticosteroids reduce mortality from TBM at least in the short term. And the clear-cut rationale for using TBM is to reduce cerebral edema. You know, TBM may be complicated by the occurrence of cerebral edema, a raised ICP, vasculitic infarcts, hyponatremia, and so on and so forth. There are n number of complications that occur with TBM. So with TBM, cerebral edema is helped by the administration of steroids. They should remain part of standard therapy, and this has been published in Lancet 2016. The choice of steroid, it may be dexamethasone, it may be prednisolone, either can be used with a choice based on ease of administration. The treatment duration is 4 weeks with subsequent gradual tapering over 2 to 4 weeks. So for TBM, yes. For herpes simplex, now steroids may have an anti-inflammatory effect or they may have a suppression of host immune response that limits viral replication. So it is a two-edged sword. So what do we do in the acute phase? No. Within 1 to 4 days? No. Usually avoid, but then in the long term, after 4 days, when the patient starts to develop complications, cerebral edema, steroids may be helpful. So there is a trial, a GACHE trial going on, currently enrolling patients with HSC to assess outcomes of treatment with acyclovir against the outcomes of treatment with acyclovir plus dexamethasone. So the results are yet to be out, but then they say adjuvant use of steroids has been recommended and used to reduce cerebral edema in patients with severe herpetic encephalitis. To summarize, this is the ENLS protocol. Meningitis encephalitis, if you suspect you have fever, headache, meningeal symptoms, stiff neck, begin resuscitation, start antibiotics, do a head CT if indicated, do a lumbar puncture, and depending upon the CSF findings, treat. Thank you. And I don't think they have the strength to ask questions.
And if anybody wants to have questions,